Socket reconstruction. What is a socket? An eye socket is the hollow cavity in the skull called an orbit in which the eyes are located. An eye socket is meant to indicate the space posterior to the eyelids and anterior to the muscle cone that is created after removal of the eye. The basic aim is to retain an eye prosthesis or shell to simulate the missing eye with a reasonably good cosmetic appearance. A socket unable to retain a prosthesis is called inadequate or contracted socket. Facial growth is influenced by the orbital growth. What are the goals of treatment? To fit a prosthesis is the main goal. Socket lined with mucosa and fornix of adequate depth, eyelids with adequate horizontal and vertical length, adequate height of lids and tightness, volume replacement, cosmesis and symmetry. A thicycle eye was enucleated and an acrylic implant was placed. A custom-made prosthesis is placed to emulate an eye. The procedure should involve limited dissection in the fornices and ensure that the extraocular muscles are placed in the normal anatomic positions so as to minimize the shortening of fornices. An implant is placed in the socket. If for some reason the implant cannot be placed primarily, a secondary implant is placed a few weeks later. The implant is placed to augment the volume loss due to enucleation and to prevent a cosmetic deficiency in the periorbital area. A custom-made prosthesis is inserted after about 6 weeks once the edema has subsided. Secondary implant placed here after 6 weeks and custom-made prosthesis over the socket. Evisceration is removal of the contents of the eyeball retaining the sclera. The extraocular muscles along with scleral cord and optic nerve are left undisturbed. An implant is placed in the scleral shell. The cosmetic outcome of the evisceration procedure is superior to that of enucleation as there is less volume loss and some capacity for movement may be retained. Evisceration is indicated in painful blind eye and panophthalmitis. Any suspicion of the presence of an intraocular tumor is main contraindication. Technique. General anesthesia is the preferred choice unless it is contraindicated due to the general condition of the patient. A curved incision is made above the superior limbus through the sclera. The choroidal tissue and intraocular contents are removed. The uvea is separated all around and removed using the evisceration spoon. Profuse bleeding will occur at this stage but will subside once all the uveal tissue has been removed. A cotton bud dipped in 10% alcohol may be used to remove the remaining uveal tissue. Bipolar cautery is used to control other bleeding points. A spacer is used to assess the size of the implant, which can be placed in the scleral shell without any tension. After placing the implant, the sclera is closed with 5-0 vicryl suture and the tenons and conjunctiva are sutured using 6-0 vicryl. A suitable size conformer is placed and the eye is patched for 48 hours. As Mustade puts it, the eye socket is meant to indicate the space posterior to the eyelids and anterior to the muscle cone that is created after removal of the eye. The function of the socket is to retain an eye prosthesis to simulate the missing eye. If the socket is able to retain the eye shell or prosthesis, it is considered to be an adequate socket. If it cannot, it is a contracted socket. Adequate depth of the superior and inferior fornices are essential to hold the eye shell in socket. Causes of contracted socket can be congenital like anophthalmia, microphthalmia, or rare craniofacial clefts. Acquired like trauma, infection, cicatrizing conjunctival disease, iatrogenic surgery related like fibrosis from initial injury, poor surgical techniques, multiple socket operations. Post-irradiation, implant and prosthesis related like ill-fitting, implant migration and exposure, not wearing the prosthesis. Management of congenital contracted socket immediately after birth or infancy, later early childhood, and later in childhood when the orbital growth has ceased. Evaluation, anophthalmia, microphthalmia, potential for vision is there or no, eyelid abnormality, condition of socket, facial development, and bony orbital growth. Congenital contracture of the eye socket. Congenital contracted sockets are seen in anophthalmia, microphthalmia, and craniofacial clefts. The growth and development of eyelids, fornices, and bony orbit depend on the presence of a normal-sized eye. In turn, the development of the face depends on the growth of the bony orbit, as it occupies the central third of the face. In anophthalmia, there is complete absence of ocular tissue. It may be unilateral or bilateral. True anophthalmia is quite rare. The term microphthalmia includes a spectrum of conditions ranging from small-sized but functioning eye to one which is shrunken with hypoplasia of eyelids and orbit. Sometimes a large cyst is seen attached to the sunken eyeball. Child is brought for the first time immediately after birth or during infancy. The tissues are pliable. There is rapid growth of soft tissue and bone. Socket enlargement with progressively increasing size conformers is done. Child is seen after birth during infancy. The socket enlargement is started early with conformers of progressively larger in size, continued till the conformer can be replaced with an eye shell. The eye shell is also replaced with a larger shell till it matches the other eye. This simulates the bony growth also. Congenital microphthalmos in a neonate, dumbbell-shaped expander, expansion of socket achieved to accept eye shell. Congenital socket contracture, a dumbbell-shaped expander is being used. Expansion of the socket with progressively increasing eye shells. Child is brought the first time in early childhood. If due to deficiency of lining expansion is not possible, surgery to enlarge the socket is done with mucous membrane graft from lip or buccal mucosa or hydrogel or self-expanding implants or dermolipomatous graft is used. Surgery to enlarge the socket. Hydrogel are self-expanding implants. They are made of copolymer methyl methacrylate and vinyl pyrrolidone. For the socket, they are hemispherical. Once the socket has expanded sufficiently to retain a prosthesis, an intraorbital spherical implant is used to encourage bony growth. Intraorbital implant should be done before 5 to 7 years of age, as the maximum orbital growth is achieved by then. You see a congenital anophthalmos in a contracted socket. Hydrogel implant was placed. Expansion was satisfactory to fit a prosthetic shell. So progressively increasing sized eye shell is used to enlarge further. Orbital cyst in a microphthalmos or anophthalmos. Congenital cystic eye is a rare ocular and orbital malformation describing an intraorbital cavity lined by neuroglial tissue. Cyst may be associated with microphthalmic eye. The eye may have vision, which vision potential. Microphthalmos with cyst, it is caused by failure of fetal fissure to close and the proliferation of neuroepithelium through the opening. It can be associated with microphthalmos, which is seen at 4 weeks of embryonic life. It can be unilateral or bilateral and can be associated with intracranial anomalies. Clinical presentation: inability to open the eye at birth due to orbital mass is the usual presentation. The cyst can vary in size. It's transilluminant and appears grayish blue in color. Large cysts usually extend inferiorly and cause remodeling of orbital walls. The microphthalmic eyeball being shifted upwards. The enlargement of the cyst may be due to fluid produced by glial tissue. The diagnostic techniques are ultrasonography, CT scan. The mass is hypodense. Hypodense globe may be small. Single or multiple cysts may be seen around the rudimentary globe. Large cysts produce remodeling of the orbit. Treatment: aspiration of cyst and sclerosant injection. The sclerosant injections are sodium tetradecyl, fibrin glue, or bleomycin. One can excise it with or without enucleation of the thicycle glue. Here you see a case of a bilateral orbital cyst. On the right side, it was excised and CMP was placed for both the sides. Another orbital cyst. The orbital cyst was excised and the prosthetic eye shell placed for both sockets. Sclerosant injection into the cyst, which was subsequently excised. Sclerosant injection into the cyst. Subsequently, patient developed entropion, which was corrected. Presentation in late childhood, when orbital growth has ceased. There is loss of fornices, laxity of lower eyelid, shortage of posterior lamella, upper and lower eyelid may have a shortage. There may be an abnormality in the eyelid, bony orbit and facial asymmetry. Management: by doing inferior and superior fornix forming sutures, lateral canthal tendon tightening, MMG palatal graft or DFG, inferior fornix forming sutures, anchoring to orbital rim with conformer. Thicical eye, inferior fornix is flattened, which was formed, and eye shell could be placed once the sutures were removed. Congenital contracted socket, lateral canthal tendon was reconstructed using a periosteal flap. Subsequently, eye shell could be placed, and here you see the patient with clear eye shell. Contracted socket associated with orbitopalpebral anomalies. Radiological investigations are needed. Initially conformers from day one, then lid reconstruction and correction of facial soft tissue defects. If the bony orbit is too small, orbital osteotomy at a later date and reconstruction of orbital floor is done. Complete cryptophthalmos, socket reconstruction with preputial graft, and here you see after the preputial graft the eye shell has been placed. Rear craniofacial cleft, Tessier 4 and 5, expansion on the right side in a newborn with conformers, reconstruction of the cleft lip and cheek were done. Partial cryptophthalmos, upper and lower eyelid reconstruction. The upper eyelid full thickness skin graft was placed, and for the lower eyelid a nasolabial flap was utilized. Congenital microphthalmos presenting late. Mucous membrane graft to enlarge the socket. Here you can see the MMG to line the socket in good position. Eye shell was placed after suture removal for the inferior fornix forming sutures. This presentation shows reconstruction of socket in congenital socket contracture. The following presentations would show reconstruction in acquired socket contractures. These presentations are mainly for the neophytes in ophthalmic, oculoplastic and reconstructive surgery. This should generate interest in them to learn more. Thank you.